Kia ora and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners, the Auckland faculty. I'm Dr. Louise Kugler, a specialist GP, and today I welcome back to the podcast Dr. Abby Baskett to discuss tongue tie. Abby works in Auckland at Milk and Honey Private Paediatric Clinic. She also has an academic position at the University of Auckland and is involved in the postgraduate paediatric program. She works casually as a paediatrician at Starship Children's Hospital. Abby has a special interest in infant feeding and breastfeeding problems and is a qualified international board certified lactation consultant and is trained to assess and release tongue ties. Abby is a neuroprotective developmental care accredited practitioner, and her aim is to work with families to provide the best possible start in life for their babies. Kia ora, Abby, and welcome back to the podcast.
Kia ora, Louise. Thanks for having me.
So today we're talking about tongue tie. What is the prevalence of tongue tie?
That's a really great question and one that's been looked at quite a lot. And the short answer is we don't really know. But in studies, some studies have shown it to be as high as 30%, but mostly it's landing around 5 to 10% of infants.
So how is tongue tie defined?
That's another great question. And the reason why that I'm hesitating to answer that is because we also don't really have an excellent reproducible tool to measure tongue tie. There are some tools which listeners might be familiar with, and there are some which are reasonable, but as you can imagine, like in a newborn baby, it's pretty difficult to get a reproducible examination and look at function. The most accurate tools are probably the ones that just look at visual appearance of the tongue, but the tongue is a complex piece of anatomy with muscle in it, and function is quite complex. So that's why it's a controversial issue, and that's probably why the incidence is so up and down in studies.
So a neonate or infant presenting with tongue tie, what are the signs a health professional should be looking for?
So I think the first question is probably a bit before that. So if there's a problem with feeding, and I think we're mainly talking about breastfed babies here, although a baby with a severe tongue tie may also struggle with bottle feeding. If you have a woman who's coming in complaining of nipple trauma, nipple pain, and difficulty latching the baby, or the baby latches and it's painful and traumatic, then the baby's mouth should always be examined. And what you're looking for in that scenario is, first of all, visual appearance of the tongue. So if you want to have a look, there's a nice thing called the BTAT or the TABI tool, which gives you a little visual thing to look at. In a settled baby, opening the baby's mouth, having a look at what the tongue just looks like and where it's resting. So if it's resting, kind of jammed on the bottom of the floor of the mouth, that's one kind of suspicion that could be an issue. If the tongue is heart-shaped with that little kind of divot in the middle, when the baby is either crying or trying to extend the tongue, that might be increased. And then if you can get an idea of mobility of the tongue just by moving your finger around the infant's mouth, you may be able to see better if the baby is restricted. And then to some degree, palpation under the tongue to feel how much restriction is. And what you're also looking for is the frenulum, where it attaches on the tip. So a baby with quite a severe restriction will have attachment usually right at the very tip of the tongue, so that their tongue is quite stuck down.
So assessment of the breastfeeding diet needs to be comprehensive and complete. How do you approach this assessment?
That's really the most important part of it. So I have seen in my breastfeeding practice babies who have come in to see me with completely unrelated issues, like, I don't know, like head shape or something. And then I've examined them and seen they have what I would consider to be quite a significant tongue tie, and yet they've breastfed and thrived and everything's been fine. So breastfeeding is a complex setup, and you can compensate for some degree of abnormality in the tongue. And the tongue tie won't necessarily have like a functional impact in terms of speech or eating. So a feeding assessment is first the history. Is it comfortable? Does the mother have nipple trauma? Then you want to think about the baby's transfer. So is the baby transferring enough milk? So that is outputs, weight gain, and behaviour after feeding, so they're satisfied after a feed. You want to have an idea of that, and then duration of feeds. So some babies who are ineffectively transferring will take a long time to feed. So a newborn baby might take 20 to 40 minutes to complete a feed, maybe a bit longer. But by the time they get to 6 weeks, say, that should really, like, if they're still taking an hour to feed each time, then that's a bit of a red flag that something is going on with the transfer or supply. So you want to take a good history from the mother's point of view, the mother's comfort, the time taken, the baby's evidence of transferring in terms of weight gain and outputs and behaviour, and decide whether there is an issue with feeding, and then go looking for, if you think there's a transfer issue, you want to examine the baby's mouth, as well as looking at technique and how the mother's holding and a whole lot of other things.
So we've detected a tongue tie in a neonate or a baby. Do they need an intervention, or can we manage them conservatively? So how do we make that decision?
So it's all based on breastfeeding in most babies. As I said, you might see a baby with a tongue tie who's feeding normally, but usually what happens is the midwife or someone else will have identified a tongue tie as part of an assessment that I just described, and there's usually an issue with the feeding. So the only reason to do an intervention is if there's an issue with breastfeeding.
Great. So if we are referring on, who do we refer to, and what expertise are required both to assess and manage a tongue tie?
I think there's a misconception about tongue tie anatomy, which is that it's kind of like a string that attaches your tongue to the floor of your mouth. And Nikki Mills, who's a ear, nose and throat surgeon who previously worked at Starship, did a PhD on tongue tie and breastfeeding related to it. As part of that, she dissected a lot of cadaver tongues. And actually, that changed my understanding of what a tongue tie is. So it's more like a continuous covering of fascia attaching all over the base of the mouth, and then it kind of tents upwards where it attaches to the tongue. So it's, imagine like a tent sticking up and attaching to the bottom of the tongue. And it often incorporates genioglossus, and that can be sometimes described as a more posterior tongue tie. And it's really quite close or adjacent to glands and the lingual nerves there. So I think it's important that we kind of understand that anatomy when we're thinking about what happens when we do a procedure in an infant. If you're referring on for an assessment, unless you yourself are a really experienced breastfeeding practitioner, I would refer on to someone who can not only divide the fascia there and maybe release the tongue a bit, but who can also offer support around breastfeeding and determine whether it's actually necessary. Now, a lot of the time, there's another way to address the issue, or actually the tongue tie is not the most important part of the issue. So when I'm talking to families about breastfeeding issues in the tongue, I often describe it as like a sort of a jigsaw puzzle, or a thing that's made of lots of different moving parts. And just because one part is a little bit off, it doesn't mean that the whole thing will necessarily fall over. Or it could be that you thought the one part that was pivotal to the whole malfunction is actually not the most important thing, and there's something else that's contributing. So the factors that contribute to breastfeeding are really complex. The mother's experience is really important. If you have a mother who's breastfed 4 babies before, she may be able to do some workarounds for a baby that has a tongue tie. The mother's supply, so like how good her supply is and how active the baby has to be at the breast to transfer milk. The shape and the anatomy of the nipple is important. So if you've got another issue like an inverted nipple or a suboptimally shaped breast or nipple, that will make it more difficult. The neurological stage of the baby, if you like. So some babies come out, quite neurologically competent with feeding, and other babies are just really sleepy and take quite a long time to get it together. Other factors around the baby's facial anatomy, so they've got, if their jaw is set back, they've got a degree of retrognathia, for example, they may struggle, or in the positioning of their palate. So if they have a very high palate and then a degree of tongue tie, that will be more difficult for that dyad to latch than a baby that has the same tongue, but the palate looks different. So you can see it's a really complex thing. So when I see a baby and a mum together, I'm thinking about all those things. And I'll spend half an hour, or I like to spend an hour with them watching the feeding, trying to assess how important the tongue tie is in that setup. And I'll always tell the parents that, I think this will make a difference, but sometimes it actually turns out not to be the really important piece of the puzzle. And, it may not improve your feeding. So I would refer, if you can, to someone who is qualified to assess the whole picture and not just look at the tongue and see a problem and act on that.
Fantastic. That makes perfect sense. So if we do need a frenotomy, it's considered a definitive process. So how frequently is it required, and are there specific criteria for determining its necessity?
So again, that brings me back to the tools, and people have tried to use those tools. And there are some that BTAT and the TABI are used in a lot of postnatal wards, but always as part of the assessment there has to be an issue as well. So if you've got an abnormal appearance of the tongue based on a TABI tool or something similar, and there's nipple trauma damage, difficulty with transfer, then in my mind, it would be warranted to divide obvious tongue tie in that baby.
Can you talk us through that procedure?
Yeah, sure. So there are two ways that a tongue tie can be divided. So one would be with a laser, and the other way is with scissors. I use scissors because that's the way I was trained, and because when I trained with Nikki Mills about 10 years ago, and at that time, the lasers that were being used were quite diffuse and caused quite a deep thermal injury. And Nikki believed that the scarring and adjacent injury was bigger with a laser. So that's why I use scissors. And scissors are really quick. The laser, you get less bleeding, but it's a kind of longer procedure. So I've stuck with scissors for that reason. There are now lasers that are more focused, the water lasers and other types of lasers, so they don't cause as much diffuse injury as they used to. So in my practice, I swaddle the baby. I use sucrose as analgesia. This is in a newborn baby. I lift the tongue with a little Mickey scoop, and then I clamp the bit of fascia that I see, and then release and then cut. And the whole procedure probably takes less than 30 seconds. Then I put pressure on the area with gauze just to stop any bleeding. I try and do it for a minute. And then, if possible, I have the mother right ready to feed, and then I put the baby on the breast. In older babies, I sometimes use lignocaine. I don't use it in the younger babies because I don't think it adds anything.
Are there any contraindications to the procedure?
I wouldn't. Obviously, the baby has to be well. I don't do it if the baby hasn't had vitamin K. So bleeding is the most likely complication after the procedure, and I don't do it unless they've had 2 doses of oral vitamin K or intramuscular vitamin K. And I'd hesitate to do it in any baby that had a strong family history of a bleeding disorder or had bleeding with any other procedure. Other than that, a normal, healthy baby.
Fantastic. And if a baby presents to us in primary care with ongoing bleeding, what do we do? Is it just applying pressure, or is there something else?
So if a baby bleeds with me post the procedure, I put pressure again. I'd hold pressure. So you just dry gauze, pack it under the tongue, and elevate the baby's chin and push down with your fingers onto the wound for 2 minutes. If that doesn't work, the Counterstat dental gauze, I use that. I've had to use that maybe twice in the whole 8 years I've been doing tongue tie releases. And then I do have a plan. So my next plan would be, I have some adrenaline, and I would, if the baby was really bleeding after that and I was worried, I would use soaked adrenaline, but I've never had to do that. And I've thought about other things that I might use, and I guess oral tranexamic acid, but at that stage you'd be calling for help and getting the baby into an ED.
So Abby, can you please talk us through the post-operative care in a neonate or a baby?
Previous, like 5 years ago, there was a movement towards giving parents really quite hideous post-operative exercises to do with sweeping under the wound and stretching the tongue, which was probably quite difficult to do and quite painful for babies, but that wasn't evidence-based, and that's been removed. But just in case that hangs around, there's no need for any post-operative exercises. In terms of wound care, so the wound often looks quite yellowy. I often say it looks a bit like a wet scab. It's a kind of triangular, yellowy looking area under the tongue that will look like that for maybe a week to 10 days. infection is quite unlikely after a tongue tie procedure, but that would be, if you're having a look at it, just make sure it doesn't look infected. And that usually the appearance goes back to normal at about day 10 to 14.
Wonderful. Thank you for that. So thank you for your time today, Abby. To conclude our podcast, your take-home messages for our listeners.
Not all tongue ties need dividing. Assess the whole issue, have a look at feeding, think about whether there is anything else that could be adjusted. If you're going to refer for a procedure, send to someone who understands infant anatomy and physiology and also breastfeeding really well and can support the mother with breastfeeding and do a thorough assessment and not just look at the baby's tongue and mouth.
Wonderful. Thank you once again, Abby. If you're a New Zealand GP and would like to claim CPD points, our podcasts are eligible, so please log them. You'll also find a list of resources used in this podcast at goodfellowunit.org. Thanks for joining us today.